We got some pretty good cases. You guys want to go ahead and get started?
Yeah, I can start because I have to get in the car in a moment.
Yeah, no problem.
So this one kind of like looked sort of subtle at first. Well, overall it kind of just looks pretty subtle, especially after previewing some of the others.
What do you
So
think about this? What do you think about this biopsy?
yeah, punch biopsy kind of squared off.
What do you think about the quality of it?
I mean, there's like a little bit of a crush in the middle, I guess.
Maybe,
I
but
don't know.
I would give this guy an A+. I mean,
Okay. I thought you were trying to like criticize it.
no, sometimes it's giving like kudos. I mean, look how deep this thing goes. They took a great biopsy. They got all the way down into the lower part of the fat here. And, actually they may have been looking for pathology here. So this is, if you're going to do a punch biopsy to the fat, you really have to almost bury it to the point of that the white plastic kind of goes in a little bit. If you're really going to do a panniculitis biopsy for something like the trunk or lower extremity, something like that. Well, proximal extremity, lower extremity, maybe not, but it's a really good biopsy. Yeah, low power, you don't see a whole lot of inflammation, do you?
Yeah. I mean, there's this kind of hint of it sort of at the upper part of the dermis, but that really seemed just very subtle kind of around the the like perivascular spaces.
Yeah, I agree. I don't think there's much going on up here. So if you wanted to say where the pathology is mostly, where would you say it really is here?
I mean, we have this, what I think is like a sclerotic appearance of the like fat septa.
Good. Yeah. So if you looked at, this is the pathology down here. So all this stuff is, there may be some alteration of the collagen up there, but it's really, we don't see much inflammation. There's a lot going on here, but this is where the action is here. So low magnification, and if you're diagnosing panniculitis, actually you want to hang out at low power quite a bit at the beginning, because you want to classify whether it's lobular, septal, both, whether there's vasculitis or not, how much inflammation is there, what kind of inflammatory cells are in the infiltrate. So looking here, what do we really see primarily?
I mean, so it looks kind of burnt out a little bit, I would say, but like there, the septal like appearance is sort of most prominent to me, but there is like a little bit going on in the lobules, but
there's a touch, but it's minimal. But if you were going to say, I took a biopsy of you and put it right next to this, what would your septa look like of your subcutaneous?
I mean, hopefully not as like thickened as that.
Yeah, exactly. You'd be almost hard pressed to see just little tiny strands of collagen. So these are markedly thickened. These are way thicker than they should be. And as we go to higher magnification, it showed, this is really a great biopsy. I really wanted you guys to see this because it's so, this is what you see in this process when you get it early.
Okay. Yeah, so it looks like sclerotic.
Yeah, there's definitely sclerosis here. There's these thick collagen bundles, they're homogenized. There's decrease in the number of fibroblasts here. So yeah, this is a sclerotic septa of the fat. And then if you go up the top, there's maybe a little bit of thickening up here, but it's not dramatic. It's like really most of the action is deep. And this is kind of what you see when you see some of these sclerotic conditions early. They actually involve the septa first, and then they sort of go north in many cases. So yeah, absolutely. So what's your differential diagnosis of this?
I mean, so like looking at just the sort of sclerosis, I was thinking about like a deep like morpheaform type process, perhaps.
Morphea, deep morphea profunda, early morphea with panniculitis. And if you biopsy somebody who's got early morphea, they sometimes don't even really have any sclerosis that you can appreciate clinically. You just see their hands. Often hands is really a good location for that. They get kind of puffy and like they look kind of doughy. And patients will say, well, my hands, they feel kind of stiff. And you try to rub the skin over the underlying fascia and you know, soft tissue beneath that, and it won't move very much. And the reason for that is because you get, that's what in the puffy phase of scleroderma, this is what you see. Early on, you see edema and incipient sclerosis of the septa of the subcutis, and then later on, it becomes obviously more sclerotic. The fat gets replaced by the sclerotic collagen. But this is what you see in an early lesion of morphea or scleroderma or acrosclerosis, any of those kind of conditions. They all pretty much look the same. Now, what else is the differential diagnosis? So those are a few things, but what else is in the differential diagnosis of this sort of umbrella of sclerotic conditions?
I mean, I guess this would be in the same sort of area, but slightly different. And I'm not seeing eosinophils here, but like an eosinophilic fasciitis.
Good, excellent. Yes, exactly. And interestingly enough, sometimes in that condition, you don't see eosinophils in the tissue. They may have circulating eosinophils. So usually you do see eosinophils actually in the biopsy, but they don't have to. Probably, my old professor used to say it really should be called fasciitis with eosinophilia rather than eosinophilic fasciitis, because sometimes you don't see the eosinophils actually in the tissue. You just see this kind of change and they have a circulating high eosinophil count. And those people also often get that secondary to some kind of chronic or acute traumatic insult. Maybe they go exercise really hard and you know, they don't get rhabdomyolysis, but they can get eosinophilic fasciitis. And then of course they can take toxic chemicals like the toxic oil that happened a number of years ago that was tainted with some agricultural products from Spain. And there was people that were taking supplements to help them sleep better. Some of those were tainted with things that caused Schulman syndrome or eosinophilic fasciitis. So there's a number of entities that can cause that. It can also cause pulmonary problems too in some cases. But yeah, that's in the differential diagnosis. And the only way you really would be able to tell that is if you got even deeper. You have to kind of get down into the fascia. So we're not really quite that deep here. We're getting close. It's a really good biopsy. There's just one or two other things to stick in the differential. And this one's kind of interesting because these little structures right here that we saw, which we thought were sort of curious.
Is that like elastic? They're
elastic fibers. And normally, if you look at elastic, just normal dermis, so let's say we go up to the regular dermis up here, we don't really see them here very easily. Maybe they're here, but they're subtle, much more subtle. Here we can actually see them admixed with this sclerotic collagen, and they're kind of brownish. And so what other condition are you aware of that gets more of a fibrosis, that gets these altered elastic fibers that actually, if you really, really look super carefully, you can see kind of a slightly granular deposition of something on them?
I'm trying to think about where that would be. It's kind of in the panniculitis type picture.
It's actually not even really, well, it gives you the same kind of pattern. It's really more of a fibrotic process, and it can go all the way down into the fascia, the muscle, the bone, and it's a widespread systemic process.
Like a what's it called? Like NSF?
Yes, nephrogenic systemic fibrosis, absolutely. And that actually, it can give you some thickened collagen like this, but it gives you these altered elastic fibers. And if you act, those are the fibers that actually have the gadolinium that's deposited on those. And you can actually see the gadolinium if you look super carefully at some of those. They actually get these little sort of interesting little, what are called lollipop structures, these little sort of pink hyalinized structures with some fibroblasts within them. And if you look carefully, you can see the little gadolinium in those little areas. And it's the reaction to the gadolinium that the host is actually having. It causes more of a fibrotic process than a sclerotic process, but the collagen is pretty thick in that as well. So this is just a good example of an early stage morphea where the changes are really confined to the septa, the subcutaneous fat. And then as time goes on, all this fat's going to become replaced with this thick sclerotic collagen. And eventually all of this is going to be sclerotic as well. So that's just a good example of what you see in kind of the early stage. If you get it a little bit earlier than this, you don't really even see much sclerosis of the collagen. You just get kind of an edematous, thickened, swollen septa, if you will. So this is just a little bit later than that, but that's good. So it's really a nice example of a septal, almost purely septal panniculitis. Usually like erythematosuس, we get septum and some periseptal inflammation. So this is a nice example of just a pure septal panniculitis. Okay, let's give this one a go.
I can try this one. I'm not really sure what it is, but can give it a shot.
Okay.
So it looks like a shave. And the first thing that kind of stuck out to me was in the epidermis, there's these cells that have the slightly foamy cytoplasm.
Okay. Okay. So did you think it was an inflammatory or a neoplastic process?
Well, I think it's inflammatory just because it doesn't look like it's, I know we normally don't do shapes of inflammatory processes, but it's just super broad. It would be really broad for a neoplasm, but it could
Well,
be.
you guys never do shaves of inflammatory processes because you've been well trained. But that's not true about, sadly enough, many of your other colleagues out there in the world. We get lots and lots of shave biopsies of inflammatory skin disease, sadly enough. But we do get shave biopsies of neoplasms, and they can be, that's actually the technique that is a choice generally for most skin biopsies of neoplastic conditions. And yeah, they can be broad. I mean, we'd get broad shaves of dysplastic nevi that are a centimeter, so they can shave off the whole lesion. So that wouldn't necessarily be the criterion. But do you really see any inflammation in here to speak of?
No, there's not much.
No. And is that epidermis normal here?
Besides the cells with the slightly paler cytoplasm.
Yeah, those don't belong there, do they? For sure. And notice how it's acanthotic. It's a little thicker than normal. And there's probably a reason for that. So if something's going in here that doesn't belong, like maybe you got uninvited house guests that crowd into your home, they're going to kind of swell everything up and push the boundaries of what's normal there. So these cells, they don't look like they belong there normally, do they?
Right.
So that's why I think we're seeing this acanthosis and these large fat epidermal rhea. Normally your epidermal rhea are thin. These are bulbous, they're fatter than normal, they're longer than normal. And so what do you think's going on here with these cells?
I think that there's like some sort of pagetoid spread of some process that's going on, and it's kind of infiltrated like the epidermis.
Good, excellent. So when you say pagetoid, tell us what you mean by that.
Kind of just scattered all throughout the epidermis.
Good. And why do we say pagetoid? What's the origin of that term?
I think it comes from Paget's disease.
Yeah, it's basically saying, well, it looks like Paget's disease, but in some cases it isn't Paget's disease. So we say, well, what are the things that can look like Paget's disease and give you a pagetoid pattern, but it's not really and truly Paget's disease. So you have to have like a differential diagnosis here when you see this pattern. So what things do you think about when you see this pattern?
So you can think about, Paget's or extramammary Paget's.
Good. You can think about the actual disease itself, right?
Right.
Okay.
What
else?
You can think about melanoma.
Good.
I think you
Any
can get like
specific type of melanoma that tends to do that more than others?
I'm actually not, maybe like MIS.
Well, MIS is kind of a broad category, if you will. You can have MIS, lentigo maligna MIS, you can have acrolentigous MIS, you can have superficial spreading MIS. And which of those generally tends to give you the most pagetoid spread of melanocytes in the epidermis?
I'm not sure, but I'm going to guess superficial spreading.
Good. And now you'll never have to guess again. You know for sure that that's the answer. That's correct.
Right, now I know.
I don't know if the board would ask that, but they might. I mean, that's theoretically fair game. So what else is in that differential?
You can get like pagetoid Bowen's disease.
Good. Excellent. Absolutely, you can get that. And there's a few others.
There's a few that I can never remember the exact carcinoma. Oh, well, Kishan is here giving me a hint that it's Merkel also.
Merkel is one. Good.
Kishan.
That's one. There's a couple of others.
And then, well, there's also a couple carcinoma. I can't remember if it's like renal or bladder or something that like metastasizes to the epidermis, and I can't remember, or GI type of cancer maybe.
Those do, and they basically are like the extramammary Paget's disease, where you get contiguous spread of the underlying GU or GI carcinoma. So that's kind of in the same category as extramammary Paget's. There's a type that's primary, that has nothing internal. And then there's a type that's got the internal cancer that spreads. So when you get a patient that's got this, you have to work them up and make sure that they don't have an internal cancer. But there's a couple of other neoplasms too that can give you a pagetoid intraepidermal involvement.
You could do like I think sebaceous carcinoma.
Sebaceous carcinoma is one. That's very good. And there's
I don't have any other
two others that are in the
ideas.
lymphoreticular category.
I will phone a friend. I'm not sure anymore.
Okay. Well, mycosis fungoides.
Oh,
That's
right.
so-called pagetoid reticulosis, and especially the Warren J. Collop type or the Ketron Goodman type. It's almost like you have a vacuum cleaner inside the epidermis. It's sucking the lymphocytes into the epidermis because they have relatively few cells in the dermis in that condition. And then Langerhans cell histiocytosis. And then lymphomatoid papulosis also can give you that. But Langerhans cell histiocytosis also can give you a pagetoid intraepidermal pattern as well. So the good news is there's not a ton of things, but you do need to know that differential. And that's something the board could very well ask you. Now, if they showed you this photograph here, they would probably give you maybe an immunoperoxidase stain to go along with it. But there is a sign here, a nice sign here that favors one of those entities over some of the others. And I'm pointing to it right here. Do you know what the sign is that we call this here?
I'm not sure. Is it just kind of how the basal layer of cells is lining up against the DJ?
Well, yeah, exactly. The cells are suprabasilar actually. So the basal cell layer tends to be spared in extramammary Paget's disease or Paget's disease of the breast also, and the so-called eyeliner sign. Does that kind of remind you of a little maybe eyeliner? You're sticking it right on the very edge of your conjunctiva right there. So that's what people call it. To me, it doesn't look much like an eyeliner, but still, that's what it's called. And you can see that the basal cell layer here is spared, and these cells are suprabasilar. And that's very helpful because in malignant melanoma in situ, they're almost always involved. And in extramammary Paget's disease, also, that's full thickness keratinocytic atypia. So the basal cell layer there is often involved. And if you see some of those other conditions like MF and the other things like that, you'll see them lining up. You'll see the little tagging of lymphocytes at the basal cell layer. So when you see the basal cell layer that's spared like this, that tends to favor extramammary Paget's disease. Now, another couple of things that can favor it is if you see any glands that are formed in the epidermis. Obviously, if you got an intraepidermal adenocarcinoma, that would obviously favor that over melanoma or some of the other entities. And then if you can identify that there's mucin present in the cytoplasm, it's kind of hard to tell, but there is some bluish gray material in some of these cells. So most likely there's mucin in here. So this is a nice example of extramammary Paget's disease in this case. So good example of that. And that the most important thing here, obviously, is that differential. So you'll almost certainly get something about this on your board examination. So there's some things you can almost be sure that they're going to show you somewhere on the exam. So make sure you know the differential diagnosis. I would know how to sort of differentiate some of those things. I would suspect if they showed something like this, they might give you an immunoperoxidase stain, but they might throw in something like this and then just put things like MF and some other stuff in there and expect you to be able to tell that this really doesn't look anything like mycosis fungoides, the pagetoid reticulosis variant. Okay, very good. Okay, here's another one that you'll see somewhere on the exam too.
Hey, it's Kishan. This is a punch, obviously.
Good.
And
How about
a pretty good one.
Yeah, give this a good grade also. We love these. We don't like it when they kind of get down here where somebody needed to go work out. You need to go ahead and get it all the way down into the fat. So go ahead and take a real punch biopsy when you're doing it.
Yeah. Well, there's a pretty, I would call it nodular and both superficial and deep.
Good.
Infiltrate.
Excellent. And is it how deep does it go?
Quite deep onto the fat.
Yeah. Yeah. So it's both a
There's a lot
dermatitis
of-
and a panniculitis.
Yep.
Of a
Yes.
combination of this. Good.
Looks dark blue on scanning, which makes me
Excellent.
think more lymphocytic.
Perfect.
And
Can you see anything
kinda-
else at low power that is helpful?
yeah, it's kind of like periacrine or perivascular.
Definitely.
And there's
What about
definitely
the-
smooth. I don't know if those are smooth muscle or what that is there, but it looks like it's around those too.
Yeah, mostly around follicles up here. But what else can you possibly see? This is if you've got a really sharp eye, this the stuff I'm kind of pointing at here at low power. We'll see it in a second, but just at low power, if you really want to impress your colleagues, your buddies, you can say, it's got something between here that's going to favor the diagnosis immediately.
Maybe mucin.
Good, perfect. Can you see it's kind of bluish gray here? It's not.
Yeah, it looks more
that first
pale.
case of scleroderma. So yeah, so superficial and deep infiltrate, mostly lymphocytes, going all the way out of the fat with mucin. What do you think about?
It makes me think about like lupus profundus
Good.
or DM.
About our lupus, right?
Yeah.
So yeah,
Yeah.
DM usually doesn't have this dense of an infiltrate, just usually doesn't. DM and lupus can be a lot of overlap between those two. So we don't always just say, well, it can't be DM. But if we're just looking at this low power and we're going to place bets, we're going to bet on lupus here. And we're going to probably bet on that over the other lymphocytic infiltrates, right? So,
Yeah.
and you know what those are. So what goes
Um,
against those at low power here?
I was thinking like MF or LYP potentially. But I think more LYP, I guess.
Well, but that's not one of the classic lymphocytic infiltrates, right? When we
Yeah.
think about the lymphocytic infiltrates, we think about,
Are you talking about like the 5 Ls?
yeah, and you can, I generally expand that up to about 8 Ls because it kind of helps to remember a couple other things. But what's against some of the 4 Ls other than the lupus one?
Well, I think the depth of the infiltrate, number
Good.
one.
Excellent. You don't get panniculitis in polymorphous light eruption. So you don't get that in that. So you'd say this almost certainly is not going to be PMLE. What about so-called Yesner's lymphocytic infiltrate? Same
I don't
thing.
know if, yeah, I think the
You know,
depth again.
None of the others really give you this. You're going to say, yeah, if the biopsy only stopped about here, we'd probably include all those other things. But once we see this says this sort of really screaming lupus more than some of the other things. And then the mucin also, if we see mucin in here in a lymphocytic infiltrate, that favors lupus as well. So those are just some clues that will help you in distinguishing among those. Now, you mentioned lupus profundus. I agree, there is a component of that here. But if you were going to sort of separate this out and call this one of the subtypes of lupus, let's say we didn't have the fat, what would you call this subtype here? Just say it stopped here.
Yeah.
Would you call
DLE
this?
or
Well,
LPP?
well, we're still in the lupus category. Okay, so let's say we've decided it's lupus. Okay, now we're going to say which subtype. We're going to really drill down a little bit. Is this classic discoid lupus erythematosus?
Not really, but I just don't know what's so follicular. What lupus is so follicular like that, like around hair follicles.
Well, that's okay. That you can see that in this variant of lupus that we're talking about here. But why not classic DLE here? What's missing for classic DLE?
It's not very interface.
Good. Excellent. It doesn't have a thin epidermis. It doesn't really have any interface change, no vacuolar alteration, no real thickening of the basal membrane zones. We don't really see that here. So it's still lupus, but what type of lupus gives you mostly a lymphocytic infiltrate? And it could be perifollicular also with mucin, with minimal epidermal change.
Yeah, I guess tumid.
Good. Excellent. The tumid form of lupus erythematosus. And that's, if you take the old lymphocytic, Yesner's back that, Yesner and Kanoff, and Norman Kanoff actually was one of the part-time attendings at NYU when I was a resident there. Really nice guy. I think he was either a resident or med student when he actually presented the case at the New York City dermatology meeting. They used to say a Dallas derm meeting like we had last night. Well, they had like in New York, they would have all the multiple different programs would come together once a month, and they would present interesting cases, and then they would write them up in in what's now JAMA Dermatology, used to be the Archives of Dermatology and Syphilology. They would write up those case discussions, and that's where that actually ended up in the literature. It was basically like a Dallas Derm presentation that ended up in literature, and then it got its own name, and it got called lymphocytic infiltrative Yesner. And Kanoff, never, his name didn't get affiliated with it quite to the same degree, but he was on the paper also. So that's, if you look at those cases, probably a lot of them were Tumin LE, because they didn't even know Tumin LE existed back in those days. And some of them were also probably polymorphous light eruption. They might have been, pseudolymphomas. They might have even been cutaneous B-cell lymphomas. So that's probably a mixed bag, if you will, of things, but it's still in there as one of the L's. What about a gyrate erythema, figured erythema?
Why is it not that?
Yeah, what would be against that here? First of all, we have the fat involvement, and that would be
Yeah.
not so good.
I mean,
What about the mucin again?
yeah, the mucin, but it's pretty, I mean, I don't know how, I guess I would think of those as less inflammatory than this.
It tends to be less perifollicular. I'll agree with that, but they can be pretty inflammatory. If you
Okay.
see like a biopsy of, EAC, especially if it's one of these, it's associated with maybe an underlying malignancy or something, they really have a pretty dense infiltrate in many cases. So yeah, that wouldn't necessarily exclude it. What about Lyme disease? And that's why I actually include that as an additional L. That's not one of the classic 5 Ls, but actually it's, you talk about gyrate erythemas, you're talking about erythema chronica migrans. What does that look like under the microscope? What's different about that than this, for example, other than the fact that there's the mucin, if you look at the infiltrate?
I think it's primarily lymphocytic, but I don't know if there's EOs or not,
Usually, there can be
or
EOs.
if it's granulomatous at all.
Not usually granulomatous, but you can actually see lymphocytes and plasma cells in that condition. And remember, that's associated with a Borrelia infection, spirochetal infection. They tend to cause plasma cells associated with them. So that tends to give you a lymphoplasmacytic infiltrate. So if you see what looks like a superficial and deep infiltrate with lymphocytes and plasma cells, think about the possibility of Lyme or the Starry syndrome, which we know is sort of analogous to Lyme disease in the warmer climates like down here. So people get bitten by ticks. They can't really find the Borrelia in that, but it's probably just a southern version of Lyme disease. You got all the symptoms. It looks like EC, erythema chronica migrans, clinical photo pictures and whatnot. So remember that one. And then what about leukemia or CLL? That can look a lot like this too, but again, usually a little denser infiltrate and usually no mucin. And then you can get some panniculitis, but not usually, where you're getting some degeneration of fat and some early mummification of fat. So this is a nice example of lupus with probably early lupus profundus and overlying kind of Tumin LE. If you look at lupus profundus, it's really got classic lupus profundus where they really get the mummified fat and you can get lymphocytes and plasma cells, lymphoplasmacytic aggregates in the fat in that condition. But you'll almost always, about 60 to 70% of the time, you'll see overlying changes up here. And often you'll get interface change that looks like discoid lupus erythematosus, overlying lupus profundus. So a good example. They're going to show you this on the board too. They may or may not, they'll probably show you lupus profundus at some point too, but they'll definitely show you something about lymphocytic infiltrates and lupus. So you definitely will get a question or two on that. Okay. This one's kind of got a tear in it, but it shows the features pretty characteristic here. Most of you guys probably got this one pretty quickly, I would imagine.
I can go for this one. So this is probably a shaved biopsy of a papule or papulonodule.
Good.
We had already
Notice it's kind of sessile. You can imagine what this will look like in the patient, right? Sort of a dome-shaped sessile papular nodule.
You can see a bit of the normal epidermis off to the side of it. Then we discussed kind of the top of the epidermis is kind of peeling off, but probably more artifactual than
Yeah, I agree. I think a
pathological.
lot of this is artifact up here. I totally agree. These are tears in the specimen, so it's not super pretty. Notice this thing over here, though. What do you call this phenomenon?
where it's like sweeping in. It's like not.
It's got a name to it though.
I'm blanking on the name.
That's okay. It's called a collarette
Uh,
of epithelium. So can you see that? It's kind of almost like it's sort of, it's a sign of it being well circumscribed, and it almost always indicates benign. There's a few exceptions to that, but 99.9% of the time, if you get a collarette epithelium, it means it's slowly growing and it's had a chance to kind of form this epithelium that's kind of trying to sort of wall off the lesion. So in other words, if it was something like a metastasis of something, those usually don't have collarettes of epithelium. So it's a helpful finding at low magnification for benign. And you look at it and say, well, you know, it's well circumscribed, it's symmetrical, it's got all these features, so you favor benign anyway. But when you see that, that's sort of just another clue. So what kind of differentiation do you think we're looking at here?
So it's pretty dense, kind of basophilic cells. Zooming in, I thought they were mostly histiocytes, and there are a lot of multinucleated giant cells as well.
Good. Any characteristics of these giant cells?
They tend, for the most part, they tend to be wreath-like, with the nuclei kind of.
Yeah, you've got like a cluster nuclei with
yeah,
this sort of pale cytoplasm surrounding it. And look up here and see, we'll probably see some more up in this area too. So what kind of giant cells do you think these are here?
I was thinking 2-ton giant cells.
Good. So 2 + 2 = 4. What's the answer here?
So I was thinking like xanthogranuloma.
Yeah, you're thinking absolutely correct. So see, it's a fairly simple one. Now, there is a differential diagnosis of this. Okay, so we've got the diagnosis here. We're sitting pretty, and you know, we think we've got it quick. We've looked at it. So, wow, look at these great 2-ton giant cells. This has to be JXG. And then you're going to look down and you're going to see a multiple choice question. It's got 4 other potential answers. So what are some things down there that might throw you off, that might make you go back and scratch your head a little bit? If you're writing an exam question, how are you going to write it so that it just wouldn't be a boring, quick answer to an intelligent examinee?
So NXG is usually the one that I think of first. If we're thinking of more palisaded granuloma.
Yeah, you could throw that in. That's not a bad idea. What else would you maybe throw in?
So you can see 2 tons with like a dermatofibroma, but we're not seeing.
Excellent. Perfect. Very good. That's the one I was kind of hoping you would think about. What do we call dermatofibromas that have these very large cells with abundant cytoplasm and hemosiderin in there? And they don't really have classic 2-ton giant cells like this, but they have large cells that kind of look a little bit like 2-ton giant cells. What do we call that variant of dermatofibroma?
Isn't it a hemosiderotic DF? Is that the name?
Yeah, sort of, but there's another name when they have these large cells, and Dr. Ackerman described that a number of years ago also. You may not.
I feel like you're leading, but I don't know the name of that one.
Dermatofibroma with monster cells, believe it or not. So that's actually one. It can sometimes simulate malignancy, so that's kind of the only real value of kind of knowing it. What else would you maybe toss in?
Like juveniles, I mean, that's kind of the extent of my my differential for this.
Well, you could make, what if they had reticulohistiocytic granuloma down there? You know, would you kind of maybe say, wait a minute, you know, are these possibly the cells that you see in reticulohistiocytic granuloma? What do those cells look like? The reason I'm asking that is sometimes you get the right answer is great. You learn something, but you can learn almost just as much with looking at the right answers of why you didn't choose those, because they can change it up and maybe make that the right answer. And if you don't know why it's not that, then you can end up screwing up and missing another question on there. So if you really want to make sure you don't miss the question, well, then you want to really analyze the reason why it wouldn't be one of those answers. So why not reticulohistiocytic granuloma here?
So you usually think of like the larger 2-tone cells that usually pop out.
They really have 2-tone. They kind of have more of a larger they're similar cells. They're usually more homogeneous and they have kind of a pink amphiphilic cytoplasm. They don't have two-tone giant cells. They don't have the foamy, cytoplasm. If you look at the
Two-tone,
cells,
not two-tone.
yeah, and even
Yeah.
that, it's not really two-tone most of the time. It's just kind of pink amphiphilic cytoplasm. So go take a look at one of those. You can see the difference in it. And then the other thing they could possibly throw in here would be something like maybe a giant cell tumor with osteoclast-like giant cells. So once again, you don't see this morphology in those cells either. You might see cells that maybe look kind of like this, but not like this. So I would just recommend they probably wouldn't put that last one on there. That's getting a little bit more in a dermatopathology board exam kind of question, but they could definitely put reticulocytic granuloma on there and expect you to know the difference between that and this, because obviously what's the setting of reticulohistocytic granuloma that we see most of the time? The clinical setting.
I mean, it's usually a single lesion, and usually with like a malignancy, right?
Not usually single. It's actually usually
Okay.
widespread. You get reticulohistiocytosis and they get the crippling arthritis in that condition. So it can be solitary, but actually the one that we have to worry about more is when they get the multiple lesions and they get the bad arthritis associated with it. You don't get that with this, obviously. So this is usually a solitary lesion, often in a kid. Doesn't have to be a kid, but most commonly in a kid. So that's JXG or just XG. Okay, this is a good one that they could possibly show you as well. So I can get it straight here. All right. They showed me this on my board. I can remember that going way back. They don't expect you to know everything about this, but they will ask you this too at some point. And they might not expect you to get the precise answer, but they're going to expect you to kind of know what's going on here.
Hey, I can go again. This is the shape.
Okay.
And there's obviously something in the like upper dermis. It looks sort of cystic.
You think it's inflammatory or neoplastic process?
I think it's a neoplasm.
Good. And let's take a look and see, do we think it's benign or malignant, or we're not sure at this power?
I think it's benign.
Okay, why?
Well, we didn't get the whole thing depth-wise, but it looks relatively small.
Okay, good.
Um,
Kind of looks somewhat symmetrical a little bit, maybe, so you say, hey, it looks like it could be benign, right? It's good because some things break the rules. So what's something that can look benign at low magnification and fool you, and it's really not benign?
like that looks like this. I would think like digital papillary adenocarcinoma, or
Those are usually pretty big lesions, usually. But what can be small, look symmetrical, look well circumscribed, and you say, oh, it looks benign at low magnification. And then you go to high magnification. Oh my goodness, this isn't benign at all. It's malignant. Why does that happen?
Pigmented.
Well, they can be.
Why? Just the atypia, or
well, that's how you can define that it's malignant as we go to higher magnification. But what breaks the rule of the architectural rules? Looks small, looks symmetrical, looks well circumscribed. You think it's benign architecturally, and then you look at higher magnification and you say, whoops, this is not benign.
I don't know.
Metastases.
Oh, okay.
Like little mets. You've seen those people with metastatic melanoma. They get those little small showers of mets. When you biopsy one of those, sometimes they look like nevi. They're small little round nodules, and they're saying, okay, it looks like a benign nevus. Next case. Well, no. So you have to realize that even though we teach this architectural, benign stuff, you have to always make sure that it's not breaking the rules. So you have to know the limitations of the technique. So here we've got a neoplasm. And is it epithelial or non-epithelial?
It kind of looks glandular.
Then that's epithelium.
Yeah.
Right. So it's glandular epithelium. Now, does
Mhm.
this look like normal glandular epithelium that occurs in our skin?
Not to me.
No. This does not look like normal glandular epithelium. As we go look at higher magnification, what do we see here?
It looks kind of necrotic, like
Yeah, it does. It's got some of this necrosis in here. What's the morphology of the glandular epithelium?
I think it's like columnar, or they look
Yes,
almost
it
like
is
goblet cell.
columnar. Yes, it's columnar. Absolutely, it's columnar. And it's got these little tiny little sort of, maybe, I'm not sure if they're silly or what they are. There's mucin in here. There's a mitotic figure here. There's another one over here. If you look at this one down at the bottom, cells are really hyperchromatic. So now what do you think's going on here?
Some sort of like GI mat to the skin.
Good. A GI metastasis to the skin. It's exactly what this is. And they're going to show you this on the exam too. You're going to see this. Now they're not going to probably ask you where did this come from? That if you were going to say that you were favoring where it's going to come from, maybe they list breast or, prostate or, Merkel cell or something like that. What do you think this most likely, what part of the body you think it most likely came from here? I think you said it actually.
Yeah, GI.
GI, yeah. So if you see dirty necrosis centrally, that favors, colonic malignancy. This has kind of got that dirty necrotic central area. That's what you see with like lower GI cancer. This was actually a guy that had known anal cancer. So these were from the anal glandular areas there and the anal epithelium that spread to the skin. But just the main teaching points here are the fact that sometimes these metastases can kind of look small and they can low magnification. Say, oh, that looks like a benign lesion. And then you look at higher magnification, say this doesn't belong in the skin at all. So this is a metastasis. And they will ask you about a metastatic lesion somewhere. Now, what's the and they might ask you about this thing also, about the umbilicus malignancies. What's that called? When cancer's metastasize to the umbilicus. Yeah, I'm sorry, you said it. I think I didn't hear you though.
Sister Mary Joseph nodule, or
yeah, Sister Mary Joseph's nodule, and Dr. Pernichiero, who's one of the faculty, he's the ex-board member of the Zola Cooper Symposium. He tells a story that this was a scrub nurse at the Mayo Clinic years ago, and she kept noticing patient after patient that would come in with a nodule in their umbilicus. It turned out to have underlying cancer, so they actually named it after her. So it was a nurse that really originally made the observation that patients that had these nodular lesions in their umbilicus turned out to have underlying GI carcinomas in many cases. They weren't always GI; they could be GU as well, but often GI cancers, appendix or colon or something like that. So I would remember that. Now, if you wanted to do a stain for this, what stain hits GI cancers? What cytokeratin stain likes below the diaphragm versus above the diaphragm? There's two cytokeratin stains that you probably need to at least know a little bit about for kind of helping to distinguish the location of cancers.
Kishan has stepped into a patient room, but I don't know, isn't it like, doesn't CK20 hit some of these like GI ones?
Yes, it does. So CK20 is below the diaphragm, hits the GI malignancies. CK7 hits above the diaphragm. So that's a good way to remember it. So if you think of, 20 is below 7. So basically that helps you kind of distinguish these. Unfortunately, there's not too terribly many stains. If you're dealing with, say, like a primary adnexal carcinoma and a metastatic carcinoma, the staining there is not the world's best in distinguishing those. You often just have to work that up, especially if you're dealing with like a mucinous carcinoma that spreads to the skin, which this really is not. You guys have time for any more, or is that you need to get into clinic?
I think everyone logged in here actually has patients at 7:40, so I think we'll have to wrap up.
Okay, well, we will do it again next month, and thank you guys for participating.
Thank you so much.
You bet.